Thank you for coming. Today is a trauma respiratory review day, and we're just going to talk about a few things that we do here in the trauma resus room when a patient comes in as it pertains to respiratory therapy. You guys are a very important portion of our team, and when we need to have somebody who is in respiratory difficulty or needs intubation or needs a quick treatment, we rely on you. So by way of talking about respiratory therapy in the trauma room, let's just go over how the patient comes into the room and how we take care of them. The patient will come in through the room and the paramedics will bring them right alongside the gurney here. The paramedic will talk to Doc 1, and Doc 1 is the doctor who's running the code, if you will, or the trauma resuscitation. Paramedic will give a short 45-second review of what's going on with the patient.
And at that time, we want everybody to be quiet because we want everybody to get the same information at the same time.
All the doctors, the nurses in respiratory therapy is here and listening to this. At that point, the patient will be moved onto the gurney and we'll begin our resuscitation of the patient. An exception to that will be if the patient is intubated, and we'll talk about that patient after we talk about the majority of the patients that we deal with. So the patient comes onto the gurney here. The nurse 1 is taking care of the patient's vital signs. This is where you come in, working around the nurse, get the SAP monitor on the patient, count the respirations, look at their respiratory motions, and determine what the respiratory status is from your standpoint, and then call that out at an appropriate time. I have a patient, respirations are 18, they're good volumes, or I have respirations 28, they're shallow, not moving much air, or I have respirations, they're 28, not moving much air on the right side at all, looks like multiple rib fractures, letting us know what you see. Likewise, if you see bad O2 saturations, to quickly troubleshoot that, make sure the connections are all right, and make sure we're getting accurate heartbeat variation. And if we are, then doubly informing us that we have bad O2 sats. At this point, the rest...
Now, everybody in this room should start off with oxygen, truly. Now, if they come in with nasal prongs, that's fine if you want to continue nasal prongs. If you want to switch them out, you think they need to be switched out to a face mask, most of the time, probably we'd prefer a non-rebreather face mask, but all God's children in this room get oxygen, okay?
And then we move through the regular ATLS of working the patient, and during that time we'll determine whether they need to have more oxygen therapy, whether they need MDI therapy, with your assistance. If the patient appears to be rock stable and is maintaining their stats, no respiratory difficulty, then it's time to go on to your own business, back to the ICU or wherever you're working, and we'll call you if we need you. But now let's talk for just a minute about the trouble patient. The patient who either comes in intubated or the patient who develops acute respiratory distress. If the patient comes into the trauma bay and is intubated, then we really need to have your help. Hopefully we've gotten the heads up from the paramedics that they're intubated. We've got the ventilator ready, and we're ready for the patient. Patient's now on the gurney. At this point, the paramedics would like us to confirm the position of the tube by auscultation and visual inspection of the tube before the patient is moved. So we'll do a quick listen and determine the depth of the endotracheal tube, see if we think it's on just by clinical exam. Then we're getting ready to move them. When we get ready to move them, we like to disconnect the endotracheal tube from the ambu bag so that there's no chance that we
drag this across.
That we extubate the patient by mistake. So on the count of 3, 1, 2, 3, we go on 1, we just remove it. We bring the patient over on 3, hook them back up. Also, we have the capnograph to put on the patient. We have both a visual capnograph that will give a digital readout on their PCO2, and we have the small capnograph that changes from yellow to purple, yellow to purple. Important thing to remember when we're intubating a patient is we can get an initial change of color with the first few breaths, even if we have an esophageal intubation, because CO2 may be in there. So you want to get at least 5 good looks, 5 good breaths to make sure that the CO2 is still changing it back and forth.
But our personal preference, mine, is this. I like for you to have this in your hand when the patient, they break the connection, you move the patient over, have this in your hand because we want the patient to be ventilated on a regular ventilator with a tidal volume we know about and can set right away.
Patient's now on the table. We get a quick auscultation of the patient's lungs. We're going ahead and we're ventilating them with the ambu bag. Now's the time to ask, is it time to move them onto the ventilator, or are we having difficulty with the patient? We want to maintain hand bagging on this patient. Perhaps there's someone who's difficult to bag, has poor airway compliance, and we want to go ahead and stay with this because this is giving us a tactile feel for what it's like to ventilate their lungs. Now let's just review what it's like to go ahead and intubate the patient. Suppose we have a patient's declining respiratory status, multiple rib fractures, pneumothoraces, etc., for which we've treated the pneumothorax. They're still having O2 desaturation or they're not moving in enough air. It's time to intubate the patient. Predominantly, most of what we do with the intubation is set up by what we do before the intubation, making sure we have the proper equipment. So for those of us who are going to intubate, we need to have our suction catheters, our laryngoscope, our endotracheal tubes, our stylets, our ambu bags, our nasal trumpets, all our adjuncts to go ahead and bag the patient and hyperoxygenate them before we actually begin this. We also need to make sure that the nurses have the appropriate drugs that we need for the patient. You guys are at the ready with the ventilator, the ambu bags, the suction catheters to assist us in doing this procedure. So we go ahead and decide to intubate the patient. At that point, we place the patient in inline stabilization. That being, if the patient is laying here with the head, one of our doctors will come to this side of the patient and lie down and actually stabilize the patient's neck. We'll take the anterior aspect of the cervical collar off. Someone will apply cricoid pressure, and then we'll go ahead and we'll assist them with the ambu bag. Now at this point, we've not given any drugs at all, so all we're trying to do is stay with the patient's ventilation. When they inspire, we assist them.
And would that be them doing that?
Yes. Ideally, it would be you, or it would be the Doc 1 who is actually going to do this. And most of the time, it's probably respiratory therapy because Doc 1 is still getting everything ready. Remember, some of these bags have valves in them. So if you put this on the patient's, put the mask on the patient's face, they actually will not be getting oxygen flowing into the mask. Some of them do, some of them don't. So we want to actually give them just a little assist of oxygen as it goes. Now we begin our pre-oxygenation phase when we go ahead and saturate their functional residual capacity with oxygen. At this point, when we feel we've got great O2 sats, we flooded them with O2, we'll go ahead and administer our rapid sequence intubation drugs, and then we'll go ahead and begin the intubation.
Now, it's good for you at that time if the sats start dropping. I really look at you guys as the people who understand pre-oxygenation and pre-oxygenation in between attempts. So your job too is to watch the sats. Like we tell the nurses, watch for ventricular heartbeats on the monitor and tell the docs while they're intubating if that's happening or the heart rate's going up or down. But we're really looking at you to look at the O2 sats and say, I have a sat that's 94, 93, 92. Do you want to pre-oxygenate? All right? So you can ask that question. Try not to be disruptive, but if you see a sat falling and it makes common sense to you, you can ask the question quietly without being disruptive. That's your job.
At the point in which the drugs are given and the patient finally becomes completely paralyzed, let's say we give them a dose of succinylcholine plus some sedative to relax them. Now we begin to actually take over their ventilation, and so the patient will lose their spontaneous respirations, and now we need to make sure we have an adequate seal and we're not getting actual breaths, and we see that the chest rise because these few moments until we actually start the intubation, you're controlling and we're controlling this. And sometimes these patients have either very tiny faces because they're babies or very large faces, and we need just one person actually holding the mask to the patient's head, and then you would be assisting with the actual bagging. But one thing that you can really help us on is make sure we've got a good seal, because Doc 1 may not be listening for that, and we don't have a good seal here. We've got to get a better seal on this patient.
And sometimes it's hard because we're trying not to disrupt the C-spine precautions, and these patients, they're not like every other patient. We're trying to take care of the C-spine.
Now we go ahead and actually intubate the patient. Usually the first move is with a laryngoscope to look in there, followed by a suction because there's always some types of secretions that are back there, then followed by attempts with a manual oral tracheal intubation. Once the tube passes in there, the person that's holding the cricoid pressure does not release the cricoid pressure until we know we're in the right spot and we have the balloon out. So we'll go ahead, quickly put the balloon up. We'll either put our capnograph on, which will measure the CO2, or we'll put the small paper capnograph that changes yellow to purple, give a few breaths, see that we've got some CO2 return. PCO2 is 50 or 60, whatever it might be, and then we can go ahead and take cricoid pressure off. But Doc 1, and you need to watch this, should never let go of the endotracheal tube, and often does, because they're doing so much here. You've got to keep an eye on that tube. If you see Doc 1 takes their hands off the tube, get your hand on the tube and on the face so that that thing doesn't go anywhere, and just hold that, and then we'll go ahead and secure it with your assistance.
Now, if you're the one that applied cricoid pressure, look up at Doc 1 and say, can I take it off now? Why not? You know, just get a reaffirmation of that if you're the one holding cricoid pressure.
We'll go ahead and we'll get them taped. We'll reconfirm the location of the endotracheal tube. It's at 22 centimeters if it's a male. It's at 24 centimeters if it's a female, thereabouts. Auscultate and make sure we have equal breath sounds on both sides. We haven't done a right main stem bronchus intubation. Then we'll follow it up with a chest x-ray. But you guys really got to make sure that tape is the tube is secured to the patient. And it's awkward because we're working around a cervical collar, and then the anterior cervical collar comes back on. And then at that point we'll just ask, you know, do we want to continue manually bagging this patient, or can we go ahead and put him on the ventilator and then get the appropriate ventilator settings.
Now I see that the more senior ones of you guys, you'll take charge and listen to the breath sounds right away. And I think if you see that no one else is doing it, definitely be the one to listen to those breath sounds. Just take a second, take a deep breath, be sure you really hear what you think you're hearing, like I do hear breath sounds on both sides. So that's very helpful. Again, you're communicating with Doc 1, and that's who it's important that he hear you. And we tell Doc 1, please make eye contact with people when they tell you something, and please nod, yes, I heard you.
The other time that's a fairly crucial time is now when we're going to move on a newly intubated patient down to CT scan, and we're going to go on a road trip, particularly if this is someone who came in with a bad closed head injury and we're quickly moving through the resuscitation and we want to move. We've taken a lot of time now to intubate. We tend to try to make it up in the transport, and here we have to make sure that everything is ready for the transport. We have our ventilator that's ready to go. We have our oxygen tanks that are ready to go. And then we have all our tubing ready to move. And again, when we move, we get ready to move, and we disconnect the respirator, the ventilator, from the endotracheal tube, move on 3, 1, 2, 3, and then hook them back up. And likewise, when we're downstairs in the CT scanner, as we get ready to move over, we pop the endotracheal tube, disconnect the endotracheal tube from the respirator, and then move it out. It's just the safest way to do it. And oftentimes you'll see people try to just move them or say, I've got it. Just pop it off. Say, no, this is a little safer. This is the way we do it. And then put it back on. But at that point, you really have to be assertive. If there's something that you don't like that's happening with respect to the airway, to say what you feel. I don't have enough tubing here. We need to disconnect the patient. I've lost my sat meter. Just say what you need to say so that it's done safely, so we don't extubate him when he goes across. So other things that we do are the adjuncts, meter dose inhalers. Somebody has asthma, chronic obstructive lung disease. We give those to the patients that are in here, ventilated as well as non-ventilated patients. Sometimes we just have somebody who comes in and they vomit while they're on the table. Well, we've got to log roll them and quickly get them over and get a suction catheter in there. If they happen to have a face mask on at that time, we've got to get it off. And oftentimes people aren't watching that. And you just reach over and just pull the face mask off. Otherwise, they're going to inhale a mask full of vomitus. So they're little things. Today we did a bronchoscopy in here. That's another thing that you might do once in a while, particularly on an inhalation burn. And there we'll assist with placing the mask, getting the high flow oxygen, the bronch team will come in, they'll anesthetize the nares, the hypopharynx, but we need your assistance there in case the patient is beginning to have some difficulties with that, goes into bronchospasm or has some other difficulties. So that during those situations, we'd like you just to stay here and assist however that might be needed.
And then pitfalls, one of the things on the videotape that I see is sometimes when therapists are bagging, their hands are small and they're bagging really fast with small hands, one-handed. And so really think about when you're bagging these patients in here, because it makes a huge difference on how they're bagged. So you want to give the tidal volume you are thinking about giving and at a rate that's not 22. I mean, sometimes people get excited and of course they're bagging at a very high rate. And think about the size of your hands. Dr. Hoyt actually has us sometimes bring a meter with Laerdal to the trauma conference and makes the residents do it one-handed so they can see what their hand can generate. And everybody should know that when you think about it. And just to reinforce what Bruce said about when somebody says, I'm nauseated, we're going to log roll the patient. And that means we're going to keep their nose in line with the umbilicus. So we're going to roll them as a log. And that's what that means. So we're going to roll them to their side, maintaining spine, full spine precautions. So remember that we need you to help with that, but we don't want anybody being twisted when we turn them. That's really important.
If a patient comes in with a Combi tube because the paramedics could not intubate the patient or the first responders do not have the ability to intubate the patient, what we should ascertain is whether or not we've got a competent airway to start with or whether we have an incompetent airway. And then we can simply listen to the patient's breath sounds bilaterally, see if we're moving some air. Quickly get the SAT meter on. If we've got a decent SAT and we're moving air, then the immediate need to change out a Combi tube to an endotracheal tube is not there. And many times Doc 1 will be very much interested in changing that tube out. If we have a tube, that tube should be left in place until we work ourselves through the primary survey, and that then will come back and change that. Now, on the other hand, if they've got a Combi tube in and it's just barely making the saturations, or you're hearing intermittent breath sounds because the tube, the balloon in the tube is moving, then we have an emergency situation in which we have to go ahead and rapidly move into intubating the patient. In that particular instance, though, once the Combi tube comes out, we have to have someone with cricoid pressure right behind it, because chances are they've got a stomach full of gas from when the Combi tube went in. So they're at high risk of aspiration. So Combi tube comes out, quick cricoid pressure, then come on very quickly with your mask and your ambu bag. I would suggest that before we even do that, we slide a nasal trumpet in the patient and have a oral pharyngeal airway available. So as that Combi tube comes out, we can quickly suction the patient, put in the oral pharyngeal airway tube, and or put in the nasal trumpet, so that when you come on with the mask, we've got an ability to bag this patient, and quickly we'll know whether we're able to bag them or not bag them. Now, chances are not in our favor about being able to bag them because the medics couldn't do it in the field. So if it's looking like we're not able to get the SATs up, we try with the jaw thrust a little bit. Remember, we need to maintain inline stabilization. We're still not getting up. Then we just need to go for it and try to actually intubate the patient. That being said, we should have planned ahead of time if we saw a Combi tube and we were having trouble with it to tell one of the house staff on the side, get the trach tray ready. Okay, get the crike tray ready, get it set up, have somebody setting that up to the side, because we're probably only going to get one or at most two quick looks before we have no O2 sat to deal with here. They're rapidly going to desaturate on us. So 2 quick looks, see if we can get it in, and then we probably need to move to a surgical airway.
So we've said in here 3 attempts to intubate, and that's it. And also, Bruce usually talks about when you know you have a difficult airway as a doctor, you should tell the team right away. And I usually teach what you teach, which is there are 2 kinds of difficult airway. One is there's a lot of secretions in there and you can't see a thing. And the other is the really anterior airway. So if the doc who's intubating is mumbling about, boy, this airway is really anterior, then you've got to think, this is a difficult airway situation, and where are we going to go from here? So just be aware of that. I tell the nurses, if they hear that, to get out the crike tray and get out the crike tube, because we may be doing a surgical airway.
The patient who comes in who has massive maxillofacial trauma, we just have to try and stop the bleeding so that we can see to intubate those patients. And oftentimes they'll have buccal mucosal lacerations, they'll have jaw fractures. And an easy way to try and take care of that problem is just to make some very quick dental rolls with the patient. And if this cheek is all lacerated, you can simply go ahead and roll these up and just stick them in there.
That's very interesting. Is there going to be a horse's head in here?
Yeah, I know.
While he's taking that out, let me tell you guys that there is a videotape about using the Combi tube. I don't know if you knew that. And it's locked up in our Pyxis unit. And we got it from the company, so if you want to ask the resus nurse sometime to watch it on our videotape machine, I'd really like that, just so you feel more comfortable with the 2 lumens.
So, comments from you guys as to important things that you think that we need to watch out for here during the resuscitations.
No, I think we've covered just about everything I can think of right offhand.
Probably just basic stuff, so double checking that the oxygen's on and the suction's on right off. I mean, those are, I know
That's the stuff that trips you up.
it is, it's basic, but we need to make sure.
Or someone standing on the tube.
Or it gets disconnected, something was disconnected. So, but yeah, I think that was great.
Remember that if you bag somebody with really high tidal volumes and pretty fast, sometimes in the patient that doesn't have enough fluid volume, you can compromise their venous return to the right side of the heart and actually have their blood pressure go down. So if you're standing here and you're bagging and you hear the nurse tell Doc 1 that there's now a new low blood pressure since you started bagging, just be aware of that and kind of make eye contact with Doc 1. When we put somebody on a ventilator, what do we usually put them on in here?
There, you said it can be a rate of 8 to 10, vital line 700, 100%, generally people fine.
Okay, so you can kind of preset your ventilator for that. Always be thinking that. Perfect. Yeah. Okay, anything else, you guys? You are a big member of the team in here, so that's why we like for you to move with us, because we try to move like a team. So it's very important to us that new people have some kind of feeling for what we do.
That's awesome, great. Thank you so much.
Thank
bet.
you.
Thank you.